Okay, so let's start. Hello, everyone. Thank you for joining me today for this webinar. My name is Roxana Petcu. I will start by telling you something about me and introducing myself. I'm from Timișoara, Romania, and you see the map of Romania and you see where Timișoara is. It's in the western part of Romania. It's very close to the border of Hungary. And Timișoara is a very beautiful city. It's actually called Little Vienna because of its architecture. It's the city where I was born. I grew up there and I went to school. I did my medical school, my medical training there, and also the orthodontic specialty. And I work in Timișoara, although I have some collaborations also in other cities of Romania. And something about my personal life. I like very much sports. I like skiing. Last year I jumped out of a plane. It was the first time for me, and let's say I overcame some of my borders and fears. I like to play the piano. I like calligraphy, and I like to travel, which I do a lot with my daughter, Emma, and she's 8 years old. I'm an orthodontist. I practice only orthodontics. And I started teaching in 2017 or 2018. I teach a lot with my colleague Dan Lazar. Maybe you've heard of him or seen his webinars. We teach a lot about interdisciplinary cases. We talk for orthodontists and prosthodontics. And over the years, we grew quite a big community of people. And you can see in the left picture, we have boot camps, yearly boot camps, where all the people that went, or some of the people who wish, come to this meeting and present their cases, and we talk about cases, we have fun, we do sports and everything. So because I talk a lot in my courses about interdisciplinary work, about orthodontic, prosthodontic, I want to talk to you today about the key elements I think to be the most important for a successful collaboration. And the first one is communication. And because it is so important, I wrote it 3 times. And let me start by making an analogy. Just imagine there are one-player sports and there are multiplayer sports like football. And being in a multidisciplinary team like orthodontic, prosthodontic is like playing football. But the way we were brought up in school, or some of us, were like this. We are in our own clinic most of the time, more or less alone, with our patients, and having not so many interactions with our colleagues. And it's like playing football, but instead of giving the ball to the other teammates, it's like having the ball all day to ourselves and running and running and running, instead of giving the ball off and getting much further and much better to the goal, right? And this is what communication in an interdisciplinary team is like. And we are going to talk more about this. And the second very important thing is, and again, because we were taught in university, we were separately specialized. The orthodontist went this way, the prosthodontist went the other way. And each of us, we do our thing in the clinic, in our daily life. But we rarely talk together about diagnostics, about planning, and most important, about vision and about language. And this is the very important thing today, because the diagnostics, and we are going to name the diagnostics the starting point, and the treatment goals, the end point, are the same. for orthodontist and for prosthodontist. And actually, we have the same language. What does this mean? What does language mean in our case? Well, language defines the terms that actually define diagnostics. And just to have the whole picture, when we talk about diagnostics, the main important aspects, the main important part of the diagnostics, to have a complete diagnostics, are aesthetics. And now we can talk about the facial aesthetics, we can talk about the smile aesthetics, and we can talk about the teeth aesthetics. Like Profit named it, it's the macro aesthetics, the micro aesthetics, and the mini aesthetics. Then we have the TMJ function. We have muscles, TMJ and muscles. We have a functional occlusion. We have the periodontium, the airway, and let's name also the stability and the chief complaint of the patient. And these are all parts of the diagnostics process. And they are the elements that build up our vocabulary. And these are terms that are, as well as for the orthodontist and for the prosthodontist, the starting point, the A point. And then we have the treatment goals, and I found them very nicely explained in Kazumi Ikeda's last book. He says for the treatment goals, we look for optimal facial aesthetics, like we said, the macro aesthetics, the teeth beautiful and correctly aligned, the micro and the mini aesthetics, good support of the soft tissue, a stable and a functional occlusion, with stable, pain-free TMJ, a normal range of motion, without pain, no pain on loading of the TMJ, normal and healthy muscle function, a healthy periodontium, a good airway, stability in time, and patient satisfaction. And these are for us the starting point and the end point. And the third very important aspect is knowing what the other can and cannot do. And again, we know too little of this. Why? Because we rarely take time just to go for 1 day or 2 days, let's say in an in-office, at our colleagues' specialty. For example, it was an important step in my professional life to go to my prosthodontics colleagues and just sit next to them while they do their job. This is how I learned about how to do a wax up and what happens to the wax up, how they transfer the mock-up, what are they looking for with a mock-up in a patient, what is the difference between an aesthetic and a functional mock-up. And these are very important parts for me as an orthodontist to understand, so that I can get a picture of what they are able to do, and also for me to explain the patient, to have a better communication with the patient. And likewise, it is very important for the prosthodontist to spend some time with us and just to see us work, to see our possibilities and our limits, what we can and cannot do, because all of these enlarge our possibilities, or in some cases they give us very straight limits, and this is also okay as long as we know it. And another important part in this, we can set up a treatment sequence so that, again, like in a team sport, we know when each of us have a role to play and when we have to switch. And going further with this vision of the starting point, the diagnostics, and setting the treatment goals, establishing the right treatment plan is again something we do in common with our colleagues, with the prosthodontics, with the surgeon, with the periodontist. Why? Because getting from point A to point B, there are many possibilities. For each team, it might be another possibility. The important part is that we have set the diagnostics, that we have set the complete and correct diagnostics, and we have set our treatment goals, our treatment objectives. And then it is for us to decide, okay, now which is the best treatment plan for each individual case? And how can we establish that? Well, I will tell you my answer to that. It is not a scientifically based necessarily answer, but from my experience, it comes actually with experience. It comes with knowledge. It comes with having actually a team, because I often meet prosthodontists who haven't met their orthodontist, so to speak. They haven't met the person they can talk to and they can work with. So just having the team by your side is an important decisional aspect. Thinking always which is the least invasive treatment plan. In this case, risks versus benefits. Of course, it is important in which group, in which study group you are. What kind of mentors did you have? What kind of school did you go to? Because there are many schools. And I don't think there is one rule or one, let's say, one recipe for all of the cases. I think in each case, the most important thing is diagnostics, and then setting up the treatment goals and establishing which is the best treatment plans in our hands for our interdisciplinary team with our experience and knowledge. And because we are talking today about orthodontist, prosthodontist, there is an important question that I many times get from prosthodontists or GPs or general practitioners. Which is the orthodontist role in the team? And I came up with two very important answers. The first one is the orthodontist. We can simplify a complex case for the prosthodontist in order for it, when the case is finished, the prosthodontist has a much simpler one. What does simpler mean? It means a simpler case allows the GP or prosthodontist to be more conservative or less invasive with the healthy tissue of the patient, with the gums, with the teeth. And let me be more clear. We have this case, for example. It's a simple case. The man has no pain in the TMJ, no pain in the muscle. The treatment objectives for this case, for this specifically case, was to restore the worn teeth, to proper level the gingival margins, and to restore the edentulous spaces. My question is, would he have been able to do this without the orthodontist? The answer is yes, he could have been, but he would have done it with a higher cost of healthy dental and healthy gum tissue. He would need it to prepare more in the teeth. He would need to do gingivectomy for aligning the gingival margins. But yes, he would have been able to restore, to properly restore this patient and to give him a good occlusion. In the same time, with orthodontics, what can we do is we can level the arches, we can place back the teeth that are worn, and because they are worn, they have migrated, like here the upper incisors, the central and the laterals, and we can correctly calibrate the spaces so that when the surgeon comes and insert the implants, or maybe the prosthodontist only do bridges, so that the surgeon has the space in the bone and the prosthodontist has the spaces to prepare the teeth. So in the second image, after orthodontics, this patient can be restored in a much more conservative way. And now, from all these three, I will focus more on the third part, and especially on the possibilities and also limits that we can achieve together in an orthodontic prosthodontic team. And I will start with the pre-prosthetic segmental orthodontics, which I like very much, and I will show you many cases so that you can understand very good what I'm doing, why I'm doing it, and how I'm building everything up. So, segmental orthodontics, what are the indications? Mostly for pre-prosthetics, space calibration when we have missing teeth and we have migrated teeth, or we have small spaces, then we can open them up. We can correct the mesio-inclined molars, the over-erupted teeth, intrusion, uprighting of specific teeth, rotated teeth, we can put them back, and last but not least, we can help them get a little bit of ferrule effect, and we will talk about it, what it is and how can we do it. First, what is the appliance design? When we talk about segmental orthodontics, the term segmental orthodontics tells us that it is not on the entire arch, but it is on a small number of teeth. And we have two main parts. We have the anchor unit, and we will see what the anchor unit represents, but as it says, it is the fixed part of the appliance. And then we have the active unit. The active unit is the tooth that we want to move. So anchor unit and active unit. The anchor unit consists of three parts. We have the anchor teeth. Sometimes I use two teeth, sometimes I use just one. I always have one mini implant next to the anchor teeth, as close as possible. And we have the connection between the mini implant and the anchor teeth. And this connection is built up from a 19 by 25 stainless steel, which I adapt very closely and passively around the mini implant, and I bond it with flowable composite, and you will see next to my anchor teeth. So let me just start with some examples. We have this patient. He came, of course, he wanted everything to be restored. By everything, I mean the edentulous spaces. So he has some edentulous spaces in the fourth quadrant, some edentulous spaces in the third quadrant. He wanted to have the bridge redone in the second quadrant, upper left. But he works as an architect, and he lives in Romania and in the Dubai. And he traveled a lot. So a comprehensive orthodontic treatment was out of discussion for him. And he asked us to do whatever we could without putting him through a 2-year orthodontic treatment. So when we see the occlusion, we see he's canine class 1 on the right side, he's class 1 on the left side. The midline, the lower midline, it's deviated, and we see he has a crossbite, the tooth 1-6 with 4-5. He's missing actually 2 molars in the fourth quadrant. He's missing the first molar and the second molar, but because those teeth were extracted a long time ago, the second premolar distalized and rotated. And now on the panorex, we can see actually that the tooth 2-6 has a poor prognosis, has a periodontal defect, and the GP, the general practitioner, wanted to extract it. We see the edentulous spaces, and also we see he's missing the tooth 2-1. He had a thick biotype with the periopockets at 1-6 and in the second quadrant. So the treatment plan, we tried to think of a plan that did not include a 2-year orthodontic treatment, but in the same time we needed to move some teeth to calibrate the spaces and to correct the crossbite on the right side. So the first thing the GP did was the bacterial control, the initial periodontal treatment, and the extraction of the tooth 2-6, which was periodontally compromised. Then we wanted to intrude the tooth 1-6 and to correct the crossbite, so to move it more buccally. Then we wanted to close the space, to close the small gap between the lower left canine and the lower left premolar. We wanted to derotate the premolar in the fourth quadrant and to calibrate correctly the spaces in the fourth quadrant. What means calibrate in this case? We decided to leave the derotated premolar in that space, to have a space, to open up a space, a small space for a premolar between the two premolars, and to calibrate the space between the tooth 4-5 and 4-8 for 1 molar. And we decided to do everything with segmental orthodontics. And it looked something like this. So we had a segmental orthodontics in the first quadrant, in the third, and in the fourth. And I will go step by step with you. So in the first quadrant, what we did, first, we have the anchor unit. The anchor unit was 1 mini implant. The mini implant, the diameter is 1.6 millimeters and the length is 8 millimeters. I have a 19 by 25 stainless steel wire which goes around the mini implant and is bonded with flowable composite on the two anchor teeth on the premolars. And first I went with a 0.16 night eye through the premolars just to intrude the 1-6. When the tooth 1-6, when the first premolar was intruded and I corrected the position in the transversal, I also bonded the 7, the 1-7. Why? Because I also wanted to intrude this tooth and I wanted to correct the buccal crown torque because the palatal cusp of the tooth 1-7 was hanging and it gave an interference. So with the arch wire that went to the tooth 1-7, I could correct the torque of the tooth. For this treatment, in the first quadrant, the treatment time was 8 months. Now, for the fourth quadrant, first, and I will go back. I actually bonded here first the canine and the premolar because there was a small space between them and I just wanted to mesialize the premolar so that I can close the gap between the tooth 4-3 and 4-4. And after I had the small space closed, I bonded also the premolar with a couple force. I derotated it and then with a 19 by 25 stainless steel wire, I adjusted and calibrated the space. And for this part, the treatment time was 6 months. And then the shortest treatment time was for the third quadrant, where I only had to mesialize the tooth 3-4. So I had a mini implant, mesial of the canine. The anchorage was from the mini implant to the canine, only these two elements, and I mesialized the premolar, 3 months. Now, very important, I left everything passive after I finished my active treatment until the implants were inserted and until they were osteo-integrated. And I removed the appliance only just before the prosthodontist started with restoring the edentulous spaces, because I didn't want anything to come loose or to lose the progress I did, especially because he was traveling all the time, and for me this was the safest way. And in the end he was restored, and we corrected the crossbite, the rotations, the spaces were calibrated, and all the edentulous spaces were restored. The second case, also with segmental orthodontics, was actually she's the mother of a colleague of mine, and again she did not want a full comprehensive orthodontic treatment, and she wished her edentulous spaces to be restored. And the problems were in the first quadrant. She had a premolar that had rotated almost 90 degrees. Also in the third quadrant, the premolars were over-erupted, and in the fourth quadrant, the space was very small. And these were our objectives. So calibrate the space in the fourth quadrant, derotate the premolar in the first, and intrude the over-erupted premolars in the third quadrant. And again, I did everything with segmental orthodontics. Now, for the derotated premolar, I used a force couple. I used a mini implant in the edentulous space so that I can have a force from the palatal. And I used an anchorage, an indirect anchorage on the molar, so that I can have a distal force from the premolar to the molar. And now you can see in the last picture, in the fourth picture, that I have another mini implant distal. If you want to know why that mini implant is there, because this patient, I had seen her very, very rarely. So she was coming once every 6 months. And I was so afraid that I might lose a bracket, I might lose a button, I might lose a mini implant, and I could lose all of my progress. And because she was always postponing the moment for the implant insertion, I said, okay, now everything is fine, but just to be sure, I will place another mini implant distally so that this mini implant can keep everything in place. And I was actually right, because after I inserted the mini implant, I think I did not see her for 1 or 1.5 years. So I think I made the right call. Then in the fourth quadrant, I used the mini implant between the two premolars. The two premolars as anchor teeth. And for the distalization and uprighting for the molar, I only used the arch wire sequence. So I went in this case from 0.16 night eye to 19 by 25 night eye and 19 by 25 stainless steel. So 3 arch wires. And on 19 by 25 stainless steel, I placed the open coil so that I can distalize the molar. And I also added an intrusion step, because when we distalize, when we upright mesially inclined molars, we always want to control the vertical aspect. So we want to upright it and then intrude it, even while we are distalizing it. And in the third quadrant, well, everything was easy here. I just placed a mini implant with a direct anchorage so that I can intrude the premolars. And I cannot tell you how long the actual active treatment time was, because, like I said, I saw her very, very rarely between appointments. But it was not a long active treatment time. Third case, also sent to me by a colleague of mine, by prosthodontics. The patient, again, she wanted to have her edentulous spaces restored, and she had her lower molars extracted when she was a young girl. So obviously the seventh were mesially inclined and the spaces were small. And also the upper molars, the 1/6 and the 2/6, they were over erupted, 1/6 more than 2/6, like you can see. On the mounted models, we can see that the premature contacts were exactly on the distal aspects on the lower 7 and on the lower 8, because they were mesially inclined. And when they incline, the distal part goes up and oftentimes it interferes. So we had a premature contact. All the 8 were in place. She was a class 1. She had a beautiful profile, and actually nothing, we didn't need to change anything in her facial aspect or in her aesthetic part of the teeth. We only had to adjust the occlusion here. So our treatment plan again was simple: to place segmental orthodontics in all quadrants on the back teeth, to open up the spaces, to upright the 7s, but also to intrude the over-erupted upper molars. First of all, we extracted all her third molars. Then, like I said, we plan to intrude 1/6 and 2/6, and also correct this buccal crown torque that I already told you about, and then to upright the 7s and to calibrate the spaces. So, like you already seen, again we have mini implants. I always use 1.6 diameter and 8 mm length when I use in the vestibular part, and 1.6 with 10 mm in the palatal aspect, and you will see I also used here some. The arch wires, I go from 0.16 night eye. Sometimes I also place a 17x25 night eye. If not, then 19x25 night eye and 19x25 stainless steel. And I add the steps, intrusion steps, and also sometimes torque to correct this buccal crown torque. And I also added 2 mini implants in the palate with buttons on the lingual side, again for this buccal crown torque, because not all of the time the torque on the arch wire is enough. The active treatment time in her case was 5 to 6 months. After this, the implants were inserted in the lower arch, and I let everything stay passive until the implants were integrated. And again, I removed the segmental appliance only before I knew that the prosthodontics could take her and restore the edentulous spaces. So the teeth are upright, and what is here interesting to notice is the periodontal aspect, which I say has much improved from the initial aspect to the final aspect. I mean mesial to the lower 7s. And I told you I will show you how I do this bending on the arch wire. So again, it's a 19x25 stainless steel arch wire. I use a bird beak or a loop plier to do to get around the mini implant, and then again I have a bend over the incisal part of the tooth, and I bond it with flowable composite that is on the head of the mini implant and also on the tooth. And it's the same for the upper and for the lower part. Except for the lower part, here you have to be very, very careful when you build or when you bend the arch wire. It cannot be very long because it can interfere with the occlusion. And if we not pay enough attention and it stays above the occlusion or it creates an interference, the patient will bite and we will lose our anchorage. And we don't want to lose our anchorage in a segmental appliance because it's not like having all the teeth bonded. It's very important, our anchorage between the mini implant and the teeth. We see nothing has changed in the profile except she has a much more flat occlusal plane like before. And we see her now with the implants and with the crowns on the teeth 3-6 and 4-6. And she has good contacts. Nothing has changed else. And we see on the mounted models that now she doesn't have this shift anymore between the centric relation and the centric occlusion. And now all the teeth touch. And if you want to read more, I have these all these cases I've shown you published in the JCO, Journal of Clinical Orthodontics, and in the EPOS. If you want them, just write me on Messenger or on Instagram and I can email those to you. And one more case. Very defined objective to derotate and distalize the tooth to 7. And I used 2 mini implants again for a 4 scalpel. I stabilized the premolar with an implant from the palatal side, and I also added a mini implant distal of the molar, so that I can have a distal force, but I also have the possibility of playing 3-dimensional with an arch wire, because the question is, would have been 1 mini implant enough for this case? The answer is yes, but to be very precise with the 3D positioning of the molar in space, I like very much to play with torque and with steps on a 19 by 25 stainless steel arch wire. And just for this reason, I stabilized the premolar with an indirect anchorage to the mini implant, and then I could have this 3D control. Again, in 5 months, everything was ready, the implant was inserted, and everything got off before prosthodontics. And here is the finishing part. The crossbite was also corrected. And now to the very interesting part of the ferrule effect. So what is ferrule effect? It refers to the 1.5 to 2 millimeters of healthy dental tissue above the crown margin, which should be around the tooth, which gives the future restoration strength, and without it, there is not much tooth structure to build the crown on. So we have many situations in which we have teeth fractured and there is this lack of ferrule. So the prosthodontist needs this portion of tooth. And the question is, how can we get it? And we can get it in 2 ways. One, either crown lengthening by the surgeon or the prosthodontist. But crown lengthening when you have an upper central incisor and the other one has a certain level and the certain level is good, you cannot mix that up. So crown lengthening just in some cases. And the second part is orthodontic extrusion. And I will show you 2 examples so we can have this orthodontic extrusion for ferrule effect in a comprehensive orthodontic treatment with brackets on the entire arch. What we need to get this orthodontic extrusion is we need a higher force. What does this mean, a higher force? It means we activate the patient much frequent. So once every 10 or 14 days, I see the patient and I activate it so that I can get almost 0.75 or 1 millimeter movement between those appointments. So the force is much higher. The activation is done much much more frequent. And third, we need to do supracrestal fibrotomy. So we need to cut those fibers, those supracrestal fibers, so that the tooth comes just with the tooth. We have just the extrusion of the tooth without the periodontium or the bone around it. And it's, in the whole, it's a very fast orthodontic treatment. So here you can see in 19 days, in this specific case, we already got the extrusion we needed. And also a very important aspect, because we have this extrusion of the tooth that happens very quick, we always have to pay attention to the incisal margin to make it shorter, so that you can see in the second picture, the tooth gets extruded, and we don't want to have this tooth longer and to interfere with the occlusion. So we have to pay attention, and in the activation session, we need to remove almost 1 millimeter of the incisal margin. And the next appointment, we have to do this again, and next again. And let me show you also a case with segmental orthodontics. So this is a case of a colleague of mine, and she had her entire upper arch done. She needed to come for the lower part. Then COVID came and she was living far away, so she did not come anymore. And right before she wanted to get again the appointments and get the lower part done, then this happened. So the tooth 1-2 fractured, and the fracture was way below the gingival margin. As you can see, it was almost 3 millimeters below the gingival margin. So the question is, can we do in this case crown lengthening? Well, if we do crown lengthening, what happens to the gingival level? At 1-1 it will be very high, and at 2-1 it will be normal, and it won't be very aesthetic. So in this case, the endodontist still did the build up, and he placed the provisional crown for me, and I planned to orthodontically extrude this tooth. And in this case, I placed a mini implant. Again, it was 1.6 diameter with 8 millimeters length, and I wanted to have one tooth on either side. So the anchor teeth in this case are the central incisor in the upper left side and the lateral upper right. And you can see I placed the bracket much higher than the neighbor teeth, and I used an 0.16 NiTi. I did the fibrotomy, and I told the patient to come in 10 days. You can see here, after 10 days, the amount that the tooth had extruded, because you can see the incisal margin is below the opposite central. What I did here was, again, I placed the arch wire above the bracket so that I can get again an extrusion. I did again fibrotomy, and I removed a portion of the incisal margin. I saw her again after 10 to 14 days. Again, you can see the amount the tooth had extruded when we compare the incisal margins of the two centrals. And what we can see is this portion of healthy dental structure, the root. And we see this is the amount that is now below the gingival margin. And also we can notice that the gingival margin is below the 2-1. So maybe I did not do enough fibrotomy and the gum came with a tooth. Either way, now the prosthodontist or the surgeon has to do a little bit of crown lengthening. But this is again okay, because with crown lengthening there will be also more portion of healthy dental tooth structure. And now we can see where the tooth structure was, and we can see it below the gingival margin. And the treatment time, I think it was somewhere around 1 month or 1 month and a week. So it was pretty fast for a treatment. So I hope you got an idea of what can we do with segmental orthodontics, how we have to design the appliance. So there are many possibilities. Once we understand the biomechanics and the biomechanical principles, we can play around and use it in many ways to help us obtain the desired result. And we can see it is a much faster treatment, like a comprehensive orthodontic treatment. And it's a very good option, again, for people who don't want a full treatment, who live far away from us, or who don't need appliance in the entire arch. And it is something that not all prosthodontics know that we can do. And we really can help them in many, many cases with this approach. Second aspect, and I have many adult patients, and the majority of these adult patients have worn teeth. So I thought, let's talk specifically about some principles in treating adult patients with worn teeth. It's always this question that, is it difficult to treat patients with worn teeth? Well, yes and no. Why do I say this? Because first of all, we have to diagnose. And in order to diagnose, we have to understand that there are many types of worn teeth, many etiologies. We have chemical attrition, abrasion, erosion, and we have to differentiate between them and to set the right diagnostics. Then we always have to look and ask ourselves, where are the worn teeth located? Because we can have patients with generalized worn teeth and we can have patients with localized worn teeth. Why is this important? Because it gives us clues to what happens to the vertical dimension. Because patients with general worn teeth, they might have lost the vertical dimension. While patients with localized worn teeth, they have the vertical dimension established with the teeth that did not worn out. And we have those worn teeth who, because are abraded, they have erupted in compensation, and while they have erupted together with the gums and with the bone. So we have multiple implications, and we see different changes that can occur, changes in overbite, in overjet. We can see, for example, a patient with generally worn teeth that came slowly into edge to edge. And when we restore the tooth, because we restore the vertical dimension, when we open the bite, then this patient can go again to a correct overbite and to correct overjet. And we can see, like I said before, this compensatory eruption with the migration of the gums and the bone, and we can see the gingival levels that came below the other teeth. This gives us an increased exposure of the gingiva, like we are going to see in the following patient. We see the loss of tooth structure and no space for rehabilitation. And of course, we have different approaches, and they are very complex because there are complex changes. We can have orthodontics to reposition those migrated teeth to correctly level the gingival margins. And then we have prosthodontics to restore the tooth structure that was abraded. Or we can have periodontics surgery with crown lengthening, maybe also a little bit of bone removal, and then the prosthodontics part. Or we can have a combination of those. And we will see an example. The patient he came to my colleague. I did this case together with Dan Lazar, and he told us that the front teeth, the upper front teeth, were getting shorter and were getting thinner. And he always had a habit of clenching. Now, when we see he has a little bit retruded profile, and when we see his teeth, he has short clinical crowns. We see the gingival levels of the upper incisors are lower. We can see the very thin enamel of the upper incisors. We see the tooth wear on the upper teeth, also on the lower teeth. He has a class 1 canine, class 1 molar. We see the abraded canines also, and the closed envelope of function. So he has retruded inclination of the upper and lower incisors. And we see the loss of enamel also on the palatal aspect of the upper incisor, as well as on the back teeth, those small aisles where we can actually see the dentine. Except for that, he has a healthy tooth structure, no lesions, no endodontic treatments. As for the clinical examination, we know from the history that he has a habit of clenching, of bruxing. He had slight pain on the TMJ palpation in the lateral pterygoid region, no pain on loading, normal range of motion, and a slight resistance to mandibular guidance. We see the condyles, especially the left condyle, has reshaped, so we see that something is going on there. On the mounted models, we see there is a slight shift between the centric relation, what is centric relation Ciard du jour, what we could manage to register on the day he came in, and the centric occlusion. This is our functional evaluation chart, so everything I told you, we are writing that down. And from time to time, we check the patient to see what's happening, if he's improving. And now we write everything down in order to make a problem list. So we know the chief complaint was that the teeth, the upper incisors, were getting thinner and shorter, and the habit of bruxing. From the functional examination, we know he has a slight pain on palpation on the TMJ, but he has a normal range of motion, no pain on loading, and a slight resistance to mandibular guidance. And this is what first I saw it in the Dawson Academy, and then also in Frank Spear. they give the patient colors according to what the functional evaluation looks like. So this patient has somewhat of an occlusal muscle disorder according to Dawson, so he's with a yellow color. If he would have an internal derangement of the TMJ with an active erosion or pain on loading, then he would have been a red patient, a red flag patient. And of course, if everything would be fine, no pain, no resistance to mandibular guidance, he would have been a green patient. Green patients means we have a go in treating him, either orthodontically or prosthodontically or whatever. So the yellow color means we have to do something because this patient has an occlusal muscle disease and he has high muscle activity. We have to do something to decrease his high muscle activity. So he was in treatment at my colleague, who treated him with an anterior bite appliance. And the anterior bite appliances are very good in decreasing the high muscle activity of the patient. We give them to patients, only to patients who don't have TMG problems, who don't have TMG pain, don't have pain on loading. So they only have muscle issues, and not for longer than 2 weeks, and he wore it only nighttime. So after these 2 weeks, he was much easier to guide with no resistance to muscle, to mandibular manipulation, and he had a green, so that meant go for the diagnostics and for the planning and for the treatment. So we start planning only for a patient who has a green color. From a facial and dental aesthetics point of view, we see he has no asymmetry, no mandibular asymmetry. He had a good proportion, skeletal class 1, no upper incisor exposure in lips at rest, no lip incompetence. We see when he smiles and when we look at the teeth, he has worn teeth with compensatory eruption. He has a flat smile arch, uneven gingival margins, and we see the retroclined upper and lower incisor. When we look at the occlusion, we see there is a slight difference between the centric relation and the centric occlusion. So we have a shift, and we notice there are some interferences, some premature contacts. We have class 1 in the centric occlusion, in intercuspidation, and we have class 2 in centric relation. And of course, we notice the restricted envelope of function. And as for the periodontal status, he has a thick biotype, no periopockets. So now we start to think, how can we help this patient? And what are the treatment objectives? And first, like Frank Spear said, we think at the upper central incisor, at the keystone for every treatment plan. So we think, where should we position the upper central incisor? We look at the proportion. We look at the given proportion. That means how long and how wide the tooth is at the moment. And we think, how big would we like to have this tooth, or what would be the ideal proportions in this case? And this will give us the ideal form of the upper central incisor. And once we have one upper central incisor, we have the other one, and then we can do this dental smile design. And we also know the gingival margins of the upper central incisors are on the same level as the upper canines, while the laterals are 0.5 to 1 millimeters below. So we already know where do we have to position gingivally to have these correct gingival margins. And from this picture, what I understand is that I have to intrude the upper central incisors, basically to bring them from where they started to wear out and to erupt. So I have to intrude them back so that my colleague will have the space to restore the worn margins. As for the treatment plan, we went for orthodontics and restorative, and like we already established, intrude the over-erupted incisors, upper and lower. Level the gingival margins, open the envelope of function, and by doing all these combination of movements, what we're going to achieve is we're going to obtain the space needed for restoring all these worn teeth. So we establish from the beginning the treatment sequence: bacterial control first, then the anterior bite appliance, then the orthodontic treatment. After the orthodontic treatment, my colleague, the prosthodontics, re-evaluates the patient. On the mounted models, if needed, he does the selective grinding. If he's doing additive, he's doing the wax up, then he's doing the mock-up, and after that he's doing the finals. So I begin with my orthodontic treatment. I like, and I always actually use the centric stops. I use the centric stops on the 7th and the 6th. I add them so that I can separate the upper and the lower arch. I don't have any interferences and the upper teeth are not biting on my lower brackets. I adjust them so that the surface is flat, so that it almost mimics a posterior bite appliance. And I always check that I have equal contacts, right and left, on all 4 of them. And I do this when I build them, and I do this at every appointment. This is a picture I take, this is actually further in treatment. Why do I take this picture? Because it gives me the upper midline, the upper dental midline, and I can compare it to the midline of the face, and I can compare the gingival margins as well as to see if I have a cant in the maxilla or the mandibula with the bipapillar plane or with any horizontal plane that I use as a horizontal reference. And here is the patient further in treatment. The treatment was not complicated. I positioned the brackets on the worn teeth, upper centrals and upper laterals, more incisal, so that I can intrude them by bracket positioning. This is one way. And the second way, like you can see in this picture, I used a lot of steps in my 1925 stainless steel, a lot of intrusion steps, until I had the gingival levels, gingival margins of the upper central incisors on the same plane with a canine. And you can see I also added an intrusion step at the lower front. And I like to maintain the centric stops. I always adjust them, like I said, each session. But I like to leave them as much as possible up to the point of 2 or 3 months before I do the intercuspidation at the end. And here is the patient before removing the appliance. We scan the patient, we virtually remove the brackets in the soft, and we mount the printed models so we can see where the premature contacts are without braces. And then I sit together with my colleague, with the prosthodontist, and we can decide, is this a moment good for us to finish the orthodontic part? Is this enough? Are all the orthodontic objectives checked? And can this patient go now into the prosthodontics part? Or do we have some more objectives that we can orthodontically resolve? So we can see now up to this point that we have intruded the upper centrals, the upper laterals. We have the upper centrals and the upper canines, the gingival levels at the same point, and also the lower incisor. And we see how much the vertical dimension, the front, the anterior vertical dimension has opened up, and also the restricted envelope of function that we had in the beginning is now open. And now the patient is finished with the orthodontic treatment. I debonded him, and Dan, my colleague, now has to re-diagnose him. He does the same setup, the same pictures. We have the same protocol, like I said in the beginning, the same vision, the same language, even the same protocols, so that nothing is different. We check the gingival margins, we check if we have an occlusal cant. And now we see, because we have opened up the envelope of function, now my colleague has enough space in the palatal aspect of the upper incisors to restore the missing morphology. Because this patient is slightly hypodivergent, my colleague decided to open him up. So just to add, and first of all he did a wax up, and then he placed the mock-up, and Denisa was our dental technician who helped us out in this case. So now the patient is with a mock-up. We test for aesthetics, we test for upper incisal exposure, we test for phonetics, and also the functional aspect, because we now want to give him functional occlusion, so contacts everywhere, simultaneous contacts with a proper anterior guidance and canine guidance. And he stayed, I think he stayed almost 2 months with a mock-up to test it out. And after that came the phase of preps and cementation of the final restorations. And these are the contacts, even, symmetric, simultaneous contacts with a good upper incisor exposure and a correct convex smile arch. Again, a good upper incisor projection in the profile view. And we see we remained with a class 1 canine, with a class 1 molar, with a correct and proper envelope of function. We see the difference. Also on the ceph, in the projection of the upper incisor, and the beautiful restored teeth. So just to sum up some notes on the worn teeth. First, we have to pay attention on the diagnostic. Which type of worn teeth are we talking about? Where are the changes located? What happened to the vertical dimension of the patient? And then, in regard to all the changes that have taken place, evaluate the treatment options regarding to aesthetics, to occlusion, to the remaining tooth structure and the root length, and the gingiva. And then select the the appropriate treatment plan for each case. So, the third part is regarding to the treatment sequence, and I will show you two cases. One is, let's say, simpler one because it does not imply the treatment of the, let's say, not a functional aspect, and the second one we'll see with a functional aspect. So the first one is Anna Maria, and she wishes to have the front teeth straight and a nice smile. And what we notice in the face of the patient, she has a long face type. She exposes much of the upper incisor and much of the gingiva. The gingiva that she exposes is as well in the front and in the lateral aspect. She also exposes much of the lower front in the lips at rest. We see she's a class 2 patient, a long face, class 2 patient. Her upper teeth, upper incisors have a positive projection towards the front, and we will see that this later. So when we look at her teeth intraorally, what we can see are the heavy crowding. That's what I saw first. I was actually a little bit scared of all that crowding, and not only of the crowding, but of the slim cortical bone and the slim arches she had. So class 2 occlusion, canine and molar, right and left, and also we see the very, very accentuated curve of Spee, and now we can understand why she exposes that much of the lower incisors in the lips at rest. We see the overjet, like I said, the heavy crowding in the upper but foremost in the lower arch, the compression that she has in the transverse aspect of the upper and lower arch. We see a hyperdivergent pattern with posterior rotation of the mandible. The upper incisors are much inclined towards the front. We see the mounted models. There is not much difference between the centric relation and the centric occlusion. So she was a green patient. She did not have any TMJ pain. She did not have any muscle pain. She did not have pain on loading. She had a normal range of motion, pain-free range of motion, and no resistance to mandibular guidance. So for us, we had the green light to go with the diagnostics and with the treatment planning. And now to the facial and dental aesthetics. Like we have a functional chart, we also have an aesthetic chart, and we go from the face to the smile and to the teeth with gingival margins, with the embrasure, the papilla, and everything. So from the face, she does not have any asymmetry, long face like stated, with overexposure of the upper incisors and the gingiva. In lips at rest, higher exposure of the gingiva in smiling. She has a hyperdivergent pattern, a class 2 with a retruded mandible. Upper and lower incisors are proclined towards the anterior. And we noticed her vertical maxillary excess. So we write everything down. Class 2 skeletal, hyperdivergent with a posterior rotation of the mandible, vertical maxillary excess, the increased exposure of the gingiva, uneven gingival margins, the flat smile arch, and the severe crowding. Occlusion, we've seen she has a class 2 occlusion with overjet, increased overbite, the very accentuated curve of Spee, and some interferences, and a very thin biotype and thin cortical bone. So we now assess the possibilities and which of the treatment plans are best suited for her. So our first thought went to orthodontic surgery because of her class 2, because of her long face, because of her vertical maxillary excess. And we think, regarding to the treatment objectives, which would be now the best treatment plan. And we thought also at a second treatment plan, a compromised treatment plan, an orthodontic camouflage with a restorative. And regarding the first treatment plan, the ideal treatment plan with surgery, yes, if we would have done orthodontic surgery, we would achieve a green check box in every option. Why did I place the question mark in satisfaction? Because her chief complaint when she first came to us was she wanted her front teeth straight and she wanted a nice smile. When I talked to her, and I talked to her about the vertical maxillary excess and about the excessive gum exposure, about the hyperdivergency of the face, about the retrognatic chin, none of these elements were her concern. So the question is, this is technically an ideal treatment plan, but if it's not satisfying the chief complaint of the patient, it is not the ideal treatment plan anymore. So then we go to the second treatment option, orthodontic camouflage with restorative. And the question is, where would we have here our limits? So my first concern was regarding her face, because if I treated her only orthodontically, I know she was still going to remain a class 2 with a retrognatic chin, probably also with a vertical excess of the maxilla and with a long face facial type. And the second question mark for me was what happened to the periodontium, what happened to the cortical bone with all of these crowdings and all of this thin cortical bone. Because I knew we could get a functional occlusion and we can maintain the health of the TMJ like it is. We can get a stability of this treatment type, and yes, as treatment, as patient satisfaction, this was the treatment type she would have wanted. Now, what can we do in her case? Well, because of the crowding, of course, we decided to extract. And we decided to extract all the four first premolars. But because we had so thin cortical bone, we also did corticotomy, and we did corticotomy with bone grafting in the lower arch from the one extraction site to the other one. And because I knew I also had to intrude the lower front to lever the curve of Spee, while my colleague did the corticotomies, he also did a corticotomy in the apical of the lower front teeth. Then the objective was to align and level the arches, to align and level the curve of Spee, obtain class 1. I knew that I would get in the upper arch a small excess of space after closing the extraction space and after distalizing the canine into class 1. So I already talked to the prosthodontics and we decided to open up small spaces lateral of the laterals, between the laterals and canines, so that the prosthodontics could get a much nicer morphology at the end of the treatment. And we knew because of her multiple carious lesions that she had, and because of the worn teeth, she needed to get into post-orthodontic equilibration. So the treatment sequence was first bacterial control, second extraction of all 4 premolars, and then the corticotomy with the bone grafting at the same day at the when I placed her upper and lower appliance. And we know the effect of the corticotomy is around 3 months. And in these 3 months, I saw her much more frequent. So I saw her once every 2 to 3 weeks. So the activation period was much faster in order to benefit from this metabolic process that happens in the corticotomy. Again, I used the centric stops. In this case, we know that the centric stops gives us an effect of intrusion. And I really needed this effect of intrusion in her case because I wanted to intrude the upper arch as much as possible to have this intrusion effect to auto-rotate the mandible. So we have the corticotomies done. We see the very accentuated curve of Spee. We see the spaces closing. Like I said, at every appointment I check and equilibrate the centric stops. In this step, I have the closed coil positioned in the upper arch. Why did I position the closed coil in the upper arch? Because I wanted to hold the upper arch, not to progress with the space closure, not until I have the lower arch completely flat, and have as much as possible the extraction spaces closed. Because first we want to establish the lower arch and then to establish the upper arch according to the lower arch. So we see in this point all the spaces in the lower arch have been closed. I placed a mini implant in the second quadrant vestibular to get more distal movement of the canine, to bring it more in class 1. We see small spaces between the canines and the laterals, a much bigger one in the left side, but that will be much closed soon. And here we do the checkup before we decide to debond her. So we check for upper incisor exposure, we check for the inclination of the upper incisor. The position and the inclination of the upper incisors are the one who gives us the position and the support of the soft tissue of the lips of the patient. So we always follow that we have a good support of the lips. We check the gingival levels, we check for any occlusal cant. We see the curve of Spee is much more leveled. We have class 1 on the right side, slight class 2 on the left side. I really struggled in distalizing the 2-3. All the spaces have been closed except of the spaces between the laterals and the canines, which we knew would remain. And now we decided to debond the patient. And that was the moment where my colleague, again Dan Lazar, started to redocument her, re-diagnosed her, and he mounted the models. He duplicated the models, and on the duplicated mounted models, he started to do selective grinding. Why? Because we always do the selective grinding first on the models and then in the mouth of the patient. After we do the selective grinding and he had all the spaces closed in the posterior, then he gave the patient correct edge to edge in the canine guidance and anterior guidance. And then he checks for the path the anterior path, the canine path, and then he duplicates everything in the mouth of the patient. So in this case, everything was done by composite, direct composite restorations. And we see we have contacts everywhere, symmetrical contacts, some simultaneous contacts, and a good upper incisor exposure. She still has gummy smile while smiling, but we knew this will be the case. And still she does look much better than in the beginning. The chin projection is much better. Why did this happen? Because by intrusion of the posterior arch, which I did also on centric stops, I also added intrusion steps in the arch, and I played a little bit with mini implants. Through this intrusion, we have this auto-rotation of the mandible. And by that, we obtain a much better chin projection. So we have a much better overbite, good overjet. The curve of spee is much more leveled. Canine class 1, almost canine class 1 on the left side, still a little bit class 2. Good incisor inclination and good forms of the arches. The mounted models, we now have contacts in every tooth. And the before and after, like I said, there is still gum exposure while smiling, but the overall aspect is much more pleasing. Also in the profile view, a slight better chin projection with a better chin to throat length. And happy patient. And now I hope you are not tired, not very tired yet. We have one more patient to go, one full comprehensive treatment. And she's a very dear patient of mine because she's a very good friend of mine. She's also the physiotherapist I'm working with on my TMD patients. So when she came, she told me that 2 years before seeing me, she had pain in the TMJ, muscle pain, she had clenching habit, history of clicking, and the cervical hyperlordosis. So now when we look at her, she has a good symmetry, a good proportion. The upper exposure of the upper central incisors is a little bit small. We wish we could have a much better exposure. We have a flat smile arch. We see the flat teeth, a slight cant, upper cant to the left. She has a class 1 profile, a neutral profile, maybe a little pointy chin, like we will also see on the Ceph. Good incisor inclination, good position of the upper lip. And when we look intraorally, we see a braided teeth. We see small spaces opening up in the lower arch with small gingival recessions. A pretty overjet, slightly 4 to 5 millimeters here. We see she has class 2 canine, class 2 molar, spaces in the lower arch, crowns in 1-6 and 2-6. And when we look at the panoramic, we see that she has fillings, crowns, and periodontal defects at the tooth 2-6 and also 1-6. On functional examination, she has bilateral clicking, no pain, and that was the moment I examined her. So not the history, but in the moment of examination. She had no pain anymore, in the TMJ or in the muscles, no pain on loading, normal range of motion, and no resistance to mandibular guidance, to mandibular manipulation. When we look at the CT, at the TMJ CT, we see some remodeling of both of the condyles, flat surfaces in the anterosuperior part with thickening of the cortical bone. And as for the position of the condyle in the fossa, especially the left one, was much more to the back and low. And these are the mounted models. And what we see different, like in the intraoral situation, we see the very, very large overjet. So it was approximately 9 millimeters to 1 centimeter, a huge overjet. Contacts only in the posterior. And now we write everything down. So for the chief complaint, she is aware of her TMD history, so to speak, of her clenching habit, problems in the cervical regions, and she wants to improve the bite. In the moment of examination, I did not find pain anymore. I did not find pain on loading and no mandibular, no muscle resistance to mandibular guidance. As for the facial and dental aesthetics, no asymmetry and good proportions, skeletal class 1, worn teeth, reduced exposure of the upper incisors, a flat smile arch, uneven gingival margins, especially at the tooth 1-2. Chin slightly forward, as I said, a pointy chin, but not skeletal, much more a thick, soft tissue. Upper incisors slightly proclined, while the lower incisors are more retro-inclined. Now, as for the occlusion, a very large overjet, we have interferences and we have a shift. We have spaces in the lower arch and canine class 2. And as for the periodontal status, we have gingival recessions in the lower front, in the premolar region, and we have those very large perio pockets at 1626. Now, the question is, she had this history of pain in the TMJ, and why didn't she have it anymore when I examined her after 2 years? Well, because, like I said, she's a physiotherapist and she's working a lot with me on the TMD patients. And once she realized the problems she had, although she did not make the courage up to get treatment, she started to do physiotherapy on herself. So everything she learned, she did on herself, and she really did it rigorously. And very dedicated, very disciplined. Every day she did her physiotherapy exercises. And it was because of that she did not have any pain anymore, and she did not have any muscle resistance to mandibular guidance. And because of this, I decided not to place her on any splint, because usually with this type of history, I would have placed any patient on splint therapy. But I did decide together with her not to go with splint therapy, but to go directly into treatment. Now, as for the treatment planning, the question is, how can we treat her? How can we close the bite? How can we correct this huge overjet? And what type of biomechanics could we use? First, I did Kennedy cuts on the mounted models. What does that mean? This means I removed the posterior teeth in order to see where the bite closes on the mounted models. And what I saw was that the overjet got smaller. It was reduced to almost a half, but I still remained with 4 to 5 millimeters of overjet. So this type, I knew I could go with posterior intrusion. It was an option. Then, as we saw on the cephalometrics, the upper incisors were a little bit retruded, so I could protrude them a little bit. And I asked the technician to do this setup for me. So, intrusion posterior, slightly procline the lower front. And then, what happened with 1626? Because they had a poor prognosis, I decided to remove them. And not only to remove them, but the spaces that remained after the extraction, I decided to mesialize the molars, to mesialize the 7 and the 8, and to have the so-called wedging effect. Kazumi Keida talks about it and he names it that way, the wedge effect, when we extract teeth and we close the bite by mesializing the posterior molars. So this is also a means of closing the bite, in addition to the intrusion of the posterior part, to get the auto-rotation of the mandible in order to reduce the overjet. So extraction of 1626, space closure with mesialization of upper 7 and 8, intrusion of posterior teeth with skeletal anchorage. This will favor the auto-rotation of the mandible. Then we'll have slight proclination of the lower front. We can distalize the canines up until canine class 1, and the remaining space will be divided between the canines and the laterals in order to build the laterals, and very, very slight retrusion of the upper front. And then the remaining overjet will be closed at the end by the prosthodontist by adding composite on the posterior aspect of the upper incisors, so on the palatal side. And I will show you everything step by step. And from the aesthetic point of view, we want to level the gingival margins. We want to intrude the tooth 1, 2, so that we can get the gingival level at the correct height. The exposure of the upper incisors will be corrected at the end of treatment by the prosthodontics. And like I already said, we will have small spaces between the laterals and the canines for build-up. The treatment sequence: first, bacterial control with extraction of 1626. Then the mini plates were inserted because I used mini plates on the buccal aspect to have much higher intrusion force and also to have a good anchor point for the molar mesialization. Then orthodontic treatment, bite appliance. Why did I say bite appliance? Because between the orthodontic treatment and the restorative part, my colleague Dan Lazar gave her an upper splint for a couple of months before going into the full mouth rehabilitation. And the restorative, after the splint therapy, was remounting, duplication of models, selective grindings on the models, wax up, then the transferred mock-up, and then to the final restorations. So I began with a treatment, again with centric stops. They helped me stabilize the mandibular position throughout the treatment. They help me intrude the posterior teeth so that I can also get from the centric stops intrusion and auto-rotation. We see the intrusion plates, buccal. So the leveling part, the teeth, the molars are mesializing. We close the spaces. I also added 2 mini implants in the palatal side with buttons so that I can have an intrusion force and also a mesialization force for the molars. And we can see the bite has closed. I still have an overjet, although it looks very good. You will see it because I also have a small movie. So I still have a little overjet, but the canines are now in class 1. What I did not manage to do, and you can see it in the third picture, the X of the tooth 26 is distally inclined, so the roots are distally inclined. Why? Because the sinus is very low in this point, and I did not manage to upright totally the tooth to 6, so the occlusion part was done through composite to improve the bite in that part. And small spaces between laterals and canines, so we see all the spaces are closed. And now this is a short movie, and you can see she's very easily guided, so no muscle resistance, and we still have up to 2 millimeters of overjet. And now this was the point where we decided to redocument everything about her and decide together with the team if it would be a good moment to debond everything. So this is the overjet at the end of orthodontic treatment before debonding. We check the facial appearance. We always check where the inclination and the position is of the upper incisor, of the lower incisor, if we have a good support of the upper and lower lip. We scanned her, removed the brackets, mounted the models to see where the premature contacts were, and from this point my colleague said, okay, it's enough, I can take it from here, and I debonded her. My colleague did again the diagnostics, and you can see here the inclined X of the tooth to 7. So like I told you, she went on a splint, on a full upper splint for 2 months before prosthodontics. And this case was done by my colleague Dan together with Daniel Jakob. So Dan mounted again the models, and he started with the selective grinding, then did everything intraorally until the molars and the premolars had contact. And we can see here after the selective grinding that the overjet is much smaller. And we now know that this entire overjet will be closed by adding composite on the palatal aspect of the upper incisors. After he did the selective grinding on the models, on the same models, he now does the wax up in order to see where he had to add composite occlusally, palatally, edge to edge, the pathways. Then he did the mock-up. He did 2 rounds of mock-ups because the first one did not have enough upper incisor exposure. So they checked everything, aesthetics, phonetics, the way she felt. And after a while, they went to prepare everything. So 1, 2, and 2, 2 were crowns, and the central incisors were partial crowns veneers. She also needed some gingivectomy and the final feldspathic ceramics. My colleague also leveled the lower incisor margins in order to get a correct pathway for the anterior guidance and for the lateral guidance. We see there are contacts everywhere. So we have a functional occlusion, we have a proper anterior guidance, canine guidance, good overjet and good overbite, canine class 1, and Manuela, who's happy with her new bite. She has no pain anymore, and she's a happy functional patient. And this was a very interesting case for us to see how can we manage such a huge overjet, and how can we use everything we know, all the tips and tricks, for us to use to close the bite. So for me, it's a very interesting learning case, and I wanted to share this with you. And my take-home message for you is, remember that we are playing a team sport. We orthodontist and the prosthodontist and the surgeon, and we always need to take a step back and focus on communication, having the same vision, having the same language, extending possibilities. And how can we do this best? And this is a call to action for you. Take 1 or 2 days and spend them in the office of your colleague. Just go, shut up and listen, because we have so much to learn from our colleagues. Just watching them talk to the patient, handle the patient, and everything they do. And invite them to do the same. And I hope you enjoyed today's lecture. If you have any questions, just write and my colleagues will let me know. If you want to keep in touch, you can write me on email, you can find me on Facebook or on Instagram. If you have questions in the future, or if you need anything, just write me and I'll be happy to help. And thank you very much for joining me today. So, if you have any questions, just let me check. So my colleagues will let me know. No questions. Okay. So either I was very, very clear or I wasn't clear at all. But either way, if you have in the future, just write me and I'll be happy to share everything. Okay, so just let me know. Okay, so no questions. Then I wish you all a pleasant evening, and I hope to see as many of you in the future live. Bye.